Welcome to Texas Heart Institute educational programs on innovative technologies and techniques. Our special guest today is Dr. Stephanie Coulter. She's a director of Women's Heart and Vascular Health.
Thank you, Dr. Krajcer, for having me. This is the second part of a series where we previously discussed medical and surgical treatment options for chronic venous insufficiencies. We are now going to discuss what are the new ways to treat these varicose veins.
Well, the newest technologies are Tumescent thermal ablation procedures, and there are two of them. One is radio frequency ablation, or which we call RFA, and the other one is laser ablation, or EVLA.
Why are they called Tumescent thermal ablation, and what are their advantages?
Well, the Tumescent thermal ablation devices generate heat between 120 to 140 degrees of centigrade. So to avoid damage to the vessels, arteries, nerves, and also surrounding tissues, we're using cold normal saline with lidocaine and sodium bicarbonate to decrease the discomfort and potential damage to the surrounding tissues and nerves. As far as the technique is concerned for tumescent anesthesia, we can see on this presentation a schematic drawing where we see the ultrasound showing presence of the truncal vein, here in particular greater saphenous vein. And then using the syringe, we can enter with a needle in the facial space and inject the local anesthetic. The purpose of the local anesthetic is to insulate the vein and insulate it also from the surrounding tissues and nerves in particular to decrease the discomfort and potential damage that can occur. On the left-hand side, we can see, again, the vein before the use of tumescent anesthesia, and then after intrafascial lidocaine injection, which separates the vein from the fascia and from the surrounding tissues, and by this we can avoid the damage that could occur with thermal ablation therapies. So what are the benefits of thermal tumescent therapies in comparison with surgical approaches? Well, the most important thing is that it's minimally invasive alternative to surgery. It has and offers fast recovery after the procedure. It has significantly lower number of complications. It has high efficacy, and this procedure can be done on outpatient basis. Obviously, the procedure is being done with the ultrasound guidance. The patient can resume normal activities immediately after the procedure, and what's also very important, it is covered by insurance companies.
So, Dr. Krajcer, where are these procedures typically being performed? In the hospital setting, or is it in the office setting?
Well, this procedure is a non-invasive procedure. So for all practical purposes, this procedure can be safely done in office setting, obviously using local anesthesia and endovascular approach. And here we can see a typical setting where we have a bed that we can raise or lower as needed. And then obviously we have ultrasound equipment that is absolutely essential, as well as equipment to deliver tumescent anesthesia with proper equipment as shown here.
I know these techniques have evolved over the last few years. Can you tell us more about the history of the technique of RFA and EVLA?
Both of the techniques are available for the last 2 decades. FDA first approved radio frequency ablation in 1999. Radio frequency ablation uses a bipolar electrode cautery to deliver radio frequency energy to the desired segment of the vein that needs to be occluded. The RFA procedure, as shown here, consists of entering the vein with a catheter, positioning the vein in a proper location in the truncal vein, activating the radio frequency, and slowly withdrawing the catheter distally This technique generates heat, as I mentioned, between 120 to 140 degrees of centigrade, and actually denudes the intima in the vein and causes fibrosis and scarring, and eventually the vein completely shrivels away and becomes just a fibrous strand. Now, as far as endovenous laser is concerned, it was approved a little bit later than radiofrequency ablation in 1990, when the technique was started, and FDA approval was achieved in 2002. Similarly, like with radiofrequency ablation, the vein is entered typically below the knee, and the probe is entering the vein, and the probe is advanced to a desired location, typically several centimeters distal from the saphenofemoral junction. The catheter consists of solid-state diode laser console that delivers energy between 10 to 14 watts, and the wavelength of different lasers varies from 810 to 1470 nanometers. Those larger frequency nanometers lasers are of a newer vintage. Obviously, we use ultrasound to locate the exact placement of the catheter. And what's very important, this kit is disposable and can be therefore used only on one-time basis. Here we can see that the vein is entered with the laser fiber, and the laser fiber is inserted into the vein. And as shown here schematically, laser is activated and is gradually pulled back, and that causes boiling in the area of the delivery of the laser energy, and the vein closes as shown here.
Dr. Krajcer, is there any difference in the pain between the two procedures, the perception for the patients, or is it similar?
There are big differences from my point of view as far as those two techniques are concerned. Laser typically uses a higher energy and higher temperature, and it definitely requires tumescent anesthesia throughout the length of the treatment segment. Radiofrequency ablation also requires tumescent anesthesia, but I would say it probably causes less pain during the procedure and definitely after the procedure. Otherwise, the techniques are very similar, and what is also very important is that we really cannot treat the whole segment of the greater saphenous vein either with laser or radiofrequency ablation because of the potential risk to damage the nerve, damage the femoral nerve, and damage the saphenous nerve below the knee. So typically for both techniques, we stop several centimeters below the knee. So that's typically the entry point for the ablation procedure using tumescent anesthesia and thermal devices.
What are your post-procedural instructions after RFA and EVLA?
Well, typically after either procedure, the patient can return to normal daily activities without any significant restrictions. We do instruct the patient they should be active on the same day of the procedure. They should walk at least 20 minutes a day for the next several days. They will require the use of elastic stockings for 2 weeks. And they might need occasionally some pain medication or one of the NSAIDs like ibuprofen for the discomfort that occurs very frequently after this type of procedure. They should avoid the prolonged sitting or standing. And the typical instructions is that they should not fly for a week or two after the procedure. And the patient should return for a follow-up within the next 2 to 3 days. And this is to make sure that no complications occur, such as damage to the nerve, excessive bleeding, or formation of thrombus or propagation of the thrombus and risk of embolization.
So on the follow-up visit, do you perform another ultrasound venous study?
Obviously, this is the most important tool and technique that we use for a follow-up, as well as talking to the patient and examining the patient.
So another question would be, why is RFA or EVLA better than surgery?
surgery or vein stripping is a surgical procedure. And it's typically done in a hospital. It's done under general anesthesia. It requires incision in an inguinal segment above the knee, below the knee, and typically also above the ankle. So there are scars and therefore potential pain and the risk of infection and the cost that's associated with this type of approach. So there are numerous advantages as far as tumescent thermal therapies are concerned. Number one, it's a non-surgical technique. It does not require general anesthesia. It causes less discomfort than surgery. It does not require hospitalization. It has a significantly lower cost than surgery, and the patient can return quicker to normal lifestyle and daily activities. Here are some of the examples as far as the studies are concerned, comparing laser with vein stripping. And in one particular meta-analysis that included 34 randomized controlled studies, stripping versus laser, there was basically no difference as far as success rate is concerned. So from that point of view, there was equivalency. But of course, there is significantly less discomfort with laser in comparison with surgery. Here's another information, and in this particular study, using radiofrequency ablation, laser with a higher rate of 14, 17 nanometers lasers, foam, sclerotherapy, and stripping is concerned. And the data that was analyzed was time to resume normal activities in days and time to resume work again in days. We can see that radiofrequency ablation and the laser offers better results as far as those parameters are concerned in comparison with stripping. And RFA was a little bit better than laser from that point of view, as we can see, but not necessarily significantly better. But obviously there was less discomfort with RFA on follow-up than with laser. And we can see this in this particular study, which is so-called recovery study on venous clinical severity score comparison of laser and closure fast radiofrequency ablation. And we can see here that as far as discomfort level is concerned, there was significantly less discomfort with radiofrequency ablation than with laser, all the way up to roughly 1 month of follow-up.
What can you tell us about non-thermal therapies for the treatment of chronic venous insufficiency?
Let's start first with, again, mentioning a few disadvantages of thermal ablation therapies. Even though they were better than surgery in many aspects, they still require certain modalities of treatment that could cause potential risk to the patient. We cannot treat all venous segment because of the potential nerve damage, particularly if we treat the veins below the knee. There's also a risk of skin burn and stain if we treat so-called suprafascial veins. Those are the veins that are easily seen with your eyes without using actually the ultrasound probe. And all of them require the use of tumescent anesthesia. And very frequently we sedate patients with oral Valium, and therefore the patient cannot drive to the procedure place or from the procedure place, and they'll need assistance from that point of view. There is also considerable training to gain proficiency in this type of treatment aspect. There is occasionally some intraprocedural discomfort, in particular if not adequate tumescent anesthesia is being used. And there is definitely some post-procedural bruising from multiple sticks to perform tumescent anesthesia. And patient will require to use compression stockings for 2 weeks after the procedure to have successful results. Now, this is particularly uncomfortable in warm climates like in Houston, right? And it's very difficult for some patients, particularly for patients that have a significant arterial disease or critical limb ischemia or infected wounds, that certainly would be very uncomfortable. So more recently, for that particular reason, less invasive technologies have evolved, and such as tumescentless and non-thermal therapies that are gaining more and more popularity because they're easier, they're simpler, they offer as good, if not better results, and the patients love it because they have less side effects and problems related to the procedure.
Can you use that therapy and do the complete saphenous vein on that one occasion, or do you have to stage it?
Yeah, so that's the beauty. So beauty of this type of approach is that we can treat the whole length of the vein that's deformed, diseased, with valvular insufficiency, meaning that we can start at the ankle and go all the way to the inguinal ligament. There is absolutely no damage to the nerve or the surrounding tissues using tumescentless non-thermal therapies. There are several of them available, as we can see here, using polydocanol or sotradecol, which is foam therapy. Those are what we call detergents-like substances that allow us to irritate or damage the endothelial layer of the vein, and that way causing sclerosis and occlusion of the vein. Then there is a so-called proprietary polydocanol foam, Varicose, that produces significantly less bubbles, microbubbles, than with physically forming foam with polydocanol or sotradecol. And then there is another one by Clarivane, so-called MOCA, or mechanochemical ablation, and we will see this in the schematic presentation shortly. And the last one is cyanoacrylate adhesive by Venocil, or Venocil by Medtronic.
Is that what we call the venous glue?
Right. This is a glue-like substance. It's very similar to superglue, so it's medically designed superglue that is absolutely safe from the point of view of putting it in the human body. Now, here are some of the results from different techniques and studies, and one is on the polydocanol with Varicose, so-called VANISH-2 results as far as symptoms are concerned, and we can see that there is a definite improvement as far as symptoms are concerned using this particular technique in comparison with baseline, and then also at 8 weeks. And we can see that we can eliminate reflux with this particular approach in 86% of patients, which is, I think, quite significant. Now, the concern with this particular approach using polydocanol from VANISH-2 studies that there was a certain small amount of thrombus extension to saphenofemoral junction in roughly close to 4% of patients, and that obviously is of concern. And there was also proximal DVT that occurred in a small number of patients, in 2.6% of patients, and distal DVT in 3% of patients. And 50% of patients for that particular reason were managed with anticoagulants, which adds an extra measure that is necessary for this particular approach.
But it's just short-term.
It's short-term, obviously, right. Now, another one is MOCA, or mechanical chemical ablation. And this particular approach uses, as we can see here, the wire that is bent, as you can see, to a certain angle, and that rotates and denudes, again, the intima and damages the intimal layer. And then also polydocanol is injected, and that gives you the opportunity to occlude the vein effectively and faster using this particular catheter technique. As far as the results are concerned with the MOCA study, we can see in comparison with RFA. And we can achieve very similar results as far as RFA at 1 month is concerned, and similar results at 6 months. However, RFA offered a little bit better results as far as closure is concerned than MOCA.
Well, what about the Venous Seal?
Yeah, we already mentioned the super glue. Now, this is the most innovative approach that I would say for treatment of chronic venous insufficiency. A lot of us interventionalists are very familiar with this substance because we have used it in cerebral circulation for cerebral aneurysms. We've used it in a lot of arteriovenous malformations, like in GI bleeding, in tumors, which very commonly is used by radiologists, and also for GU abnormalities and pathologists. And I also use it for treatment of endoleaks post abdominal aortic aneurysm replacement, particularly for type 2 endoleaks or endoleaks that occur from branches such as lumbar arteries or inferior mesenteric arteries that cause continuous flow to the aneurysm. So this particular substance is modified. It's not a super glue that you find in a hardware store. And it has been well tested. It's non-mutagenic, it's non-pyrogenic, it's non-hemolytic, and not cytotoxic. So we have used this very extensively for the last 4 to 5 years, and we have had excellent results using this particular approach.
So what's the downside to the VenaGlue? Because it sounds like of all the techniques that you've described, I'd be signing up for the venous glue first, because it seems that you can do the entire vein on one day and it offers a good outcome with the lowest level of discomfort. So is there any downside to the Venous Seal?
Well, let me show you first the technique. This is schematic video presentation of how the Venous Seal catheter is being advanced to desired location. We place it typically 5 centimeters from the saphenofemoral junction, because the glue will travel for about 3 centimeters from the catheter. We compress the saphenofemoral junction with the ultrasound probe, and we inject 0.1 milliliter of super glue, as you can see it, typically first 1 centimeter from the first injection, and then in 3 centimeters from that segment further down. We usually wait for 3 minutes to the glue to take effect in the proximal segment, and then roughly 30 seconds in more distal segments. So it's a pretty rapid procedure. Every segment is being compressed with the ultrasound probe, as you can see it, and we glue the anterior and posterior wall of the vein shut, as we can see here, very effectively and permanently in a lot of instances. And that gives us excellent result. And the catheter is removed, so we have one entry stick and only one location where local anesthesia is being done. And Band-Aid is placed at the end of the procedure, and the patient can be active the same day. We can treat both veins, greater saphenous vein, at the same time. The patients do not require elastic stockings like with typical radiofrequency or laser ablation. They can be involved in physical activity the same day, and it's a very safe procedure. Now, like any procedure, there are always potential side effects. So there are certain scenarios where this particular technique is not necessarily the best. And that would be in patients that have very large veins. And so this is where we occasionally see failures. But we found remedies for it. We give a double dose for patients that have larger veins. And there are maybe some other minor side effects, such as redness or to a certain degree allergic reaction. That typically disappears with the use of anti-inflammatory agents over a period of 1 or 2 weeks, and maybe with the use of some ibuprofen for the discomfort. I would say probably less than 5% of patients have this type of side effects, but in general, this technique is safe, and it's well tolerated, and it's well accepted. Dr. Coulter, thank you very much for the opportunity again to be here and discuss this important topic of chronic venous insufficiency, and in particular, treatment of chronic venous insufficiency. And I'm sure that at Women's Center, there will be a lot of questions among your participants and people that regularly check your website on this particular topic.
Well, I'm super happy to have you here. I learned a lot, and it's going to affect the way we take care of our patients here. And seeing the images of how easy this therapy can be implemented in an office-based setting makes it a lot less scary, especially comparing it to venous stripping, which of course requires general anesthesia. It's hard to imagine that people would be eager to have that in this day and age when such better techniques are available. But thank you so much for highlighting these important educational concepts to our viewers, and especially to our patients who are watching our video series. We are welcoming you to our future events that we're going to host to help highlight these important educational opportunities.